Good evening, everyone. I'm Don Liacono. I'm Chief Program Officer here at NAMI Davidson County. I'm welcoming you all to a Vanderbilt Behavioral Health, NAMI Davidson County collaborative education session with Dr. Eboné Ingram. Tonight's subject is Understanding Pediatric Mental Health Treatment and Levels of Care. I'd like to introduce Tracy Glasgow, who does outreach and many other things at Vanderbilt Behavioral Health and is a good community partner and a good friend. So, Tracy, why don't you take it from here?
Thank you, Dawn. We're excited to have Dr. Eboné Ingram here with us tonight. As Dawn mentioned, I'm Tracy Glasgow and I'm with Vanderbilt Behavioral Health, and I have the privilege of being in an outreach role, which means I get to interact with a lot of our community partners. And tonight we're excited. For those of you that don't know Dr. Ingram, she has been part of Vanderbilt since the start of her medical school in 2012. And she did her psychiatry residence and child and adolescent psychiatry fellowship here with us. NAMI is an organization that is near and dear to her heart, both professionally and personally. Dr. Ingram serves as our assistant professor of clinical psychiatry and behavioral sciences, and she is the medical director of our inpatient child and adolescent psychiatry unit. So she is well positioned to be here with us tonight, and I know her mom is so proud of her.
All right, thank you so much, Tracy, for the introduction.
Yeah.
All right, I am just going to share my screen. This was working a minute ago. Hopefully nothing has changed about that. Okay, I think we got it. All right, so as was said, we are talking about pediatric mental health treatment and levels of care. This is fairly informal the way I've put this together, but feel free if there are any questions. I'll try to keep an eye on the chat as well. I know Don will as well, but feel free to stop me and ask any questions at any point. Okay. As is common with many, many presentations, a good old disclosure slide. I have nothing to disclose. And so just to kind of give us a bit of an outline. So first I'll start out with some of the ways that when I'm teaching medical students or when I'm talking to patients or talking to families, some of the ways that I conceptualize levels of care in pediatric mental health, and some of the ways that as I was learning and coming up, that I would kind of keep them straight myself. We'll look at a little bit more of an overview of some of the common kind of buckets that we think of in terms of levels of care. Some additional considerations, which will go into what are some of the things that clinicians are looking at when they recommend certain treatments and certain levels of care. And if time permits, I was telling a few folks that came on early, a couple of years ago, I gave a lunch and learn that was about mental health myths and misconceptions. Cannot speak tonight. But I thought it might be interesting because it does relate to, understanding levels of care in pediatric mental health treatment. Time permitting, I figured I could, you know, show some of those myths and misconceptions and just kind of see where that leads us. All right, and just some disclaimers. For the purposes of this talk, I won't be covering specific diagnoses, details of that, medications, or types of psychotherapy. I may touch on things here and there, but really my focus with this is more about the specific levels of care. Um, because I work at Vanderbilt and I have not worked anywhere else, a lot of a lot of my conceptualization, a lot of my descriptions of some of these levels of care will be based on the way that the programs at Vanderbilt are designed. We don't have a program for every single level of care, but for the ones that we do, those are kind of the things that I know the best. So I will be relying on that knowledge as we go forward. And you can define levels of care in a lot of different ways. And so, depending on how you define levels of care in terms of, would you call it outpatient if it's not happening in a clinic and it's happening at a school? Or would there are so many different ways that you can kind of distinguish between a lot of these. this is probably not going to be an exhaustive list, and that's really intentional because we're really looking at some of the most common kind of categories that you might encounter. Okay, so looking at first at a bird's eye view. So these are the levels of care that generally exist. Some people might even loop in intensive in-home services with outpatient. Like I said, there are different ways to define it. But when I'm thinking about these services, this is kind of how I divide it out in my mind, and it kind of helps me as I'm trying to explain these to others, as you will see tonight. So, one of the other ways that I like to conceptualize and distinguish between all of these is, oops, wow, sorry. So, you can think of this in terms of how intensive the level of care is, or whatever treatment is. What is the kind of level of restriction? So, how much are we looking at safety precautions and restrictions, and are you free to come and go, et cetera? And also, how long does the treatment last? And so I like to be creative, so I kind of decided to play with a bit of a color gradient, as you will see as we keep going, just to show that each of these levels, they have some differences between, these three ways of kind of distinguishing them. And I'll also go into a little bit about, for lack of a better word, the kind of medical equivalent of some of these levels of care. I had an attending when I was a fellow who would always talk about, he would compare, you'll see the inpatient setting to like the ICU, and he had a way of kind of providing a framework that he used also when he was teaching, as well as when he was explaining to families kind of what the expectations were and what some of the goals were. And so I have adopted that from him. Shout out to Aaron Jekyll. I know he's not on this call, but that is fine. All right, moving forward. So zooming in just a little bit. So we'll start out with outpatient. So you could think of these, usually, at least for myself and my colleagues, when we're talking about outpatient, we really mean clinic-based services, office-based services. Some people would also lump in school-based services in here, where instead of the child and the family coming to the office, there may be an embedded therapist or med provider in the school that is, seeing the child and working with the family. The kind of general buckets that we think about. So, you've got medication management, which is, with your psychiatrist or psych and P, or, your clinician, your medical provider. Usually, you're looking at once a month appointments, or less frequent if things are more stable or the clinic is particularly packed and they're trying to serve a lot of different needs and just don't have a lot of space. Access to care is something that we could definitely talk about. But usually, unless there's a crisis or there are pretty significant changes you're making in the outpatient setting that you want to follow up more frequently, you're looking at probably once a month until things get a bit more stabilized. And then for psychotherapy, some of the folks that work with me have heard me say if you are doing therapy less than every other week, you're very much, your results may vary. For some folks, when I see a kid that says that they see their therapist once every couple of months, I have to kind of hold myself back from saying you're kind of not doing therapy. Because it really, there's so much to dive into and so much that goes into building rapport with that therapist and working with that family, et cetera, that you really need that constant face time to continue to build on those skills. So ideally it would be weekly or every other week, but as I said, there are lots of barriers that people can encounter both on the clinic side as well as on the patient and family side. Other examples of things that happen in the outpatient setting that may likely will not happen in other levels of care. Formal psychological testing. This is something that the question comes up quite a bit when someone is admitted to our inpatient unit. Can we get a full psychological evaluation or can we get a full psych eval? And my answer is it depends. If you are thinking the battery of tests where we look at IQ, we look at functioning level, and we get really, really specific, those are things that require the outpatient setting. But because you are in an inpatient in a setting with psychiatrists, social work, and other disciplines, you are getting an assessment. It's just not the formal battery of tests that a lot of people are kind of asking about typically. And sometimes depending on your clinic location and the way that your resources are set up, there may be other wraparound services such as case management. There may be some kind of educational things. There may be some other supports in your particular clinic that will help with hopefully not needing a higher level of care. And as I've said, I put the stars here. Oh, I keep doing that. My goodness. I'm so sorry. We have frozen apparently. Ah, going backwards instead of. Okay, there we go. Sorry. Um, but I did kind of put the stars there just for reference, but the goals and intensity and duration of your outpatient treatment may vary. So for some people, if you're doing specific types of therapy, particularly trauma work, you're probably going to be getting really, really deep into it versus if someone is doing med management with you and it's pretty straightforward, you have a pretty fast-moving clinic, you may just touch on kind of the safety points and kind of the high level things. In terms of the restriction piece, the patient can come and go and show up or not show up as they please. And so really the restrictions, it would be something like if you're talking about safety planning or like monitoring technology use and some of those recommendations that would come up in the clinic setting, those would kind of be where the restrictions would come from. But in terms of the actual office, there are very few limits, within reason on what you'd be able to bring into that appointment or access or utilize. And then duration, could be very short time frame, could be that you're seeing someone on a consult type basis. They see you a couple of times and then they have you transition back to your pediatrician, or it may be something where you have been on these meds for a long time, you're gonna need someone to follow up on them, and so you continually see them for months, maybe even years. Okay, now we're ready to go on to the slide. So like I said, with in-home services, I think some people would actually lump this into outpatient, and it's just kind of a different setting. Instead of you going to the service is coming to you. But because of the eligibility requirements around in-home services, particularly with insurance eligibility and some, geographic location also can play a role. I usually, when I'm talking about these, I think of it as a different level of care and a bit more intensive because you are seeing your provider 3 to 5 times a week, depending on the type of in-home service. And usually it's a span of a few months. But there are folks that will, they may extend the time just depending on the situation, or they may complete a round of in-home services and then, step down to another level and then do it again multiple times, just depending on the need. Um, as much as it would be really cool to do in-home services for medication management, aka house calls like we apparently used to do way back in the day before I was a doctor, um, it's primarily therapy and or case management. And a lot of this I've kind of gleaned from families that I unfortunately have had to work with on the inpatient unit multiple times. We may have referred them to in-home services, and then if they end up coming back to the hospital, they may give us feedback about, hey, I know you were trying to set me up with in-home therapy, but it turns out it was more so case management. They really just focused on safety planning. We didn't do really, really We didn't do really in-depth psychotherapy like you were hoping. Or sometimes we'll hear the opposite of, I was expecting just case management and a couple of recommendations here and there, but this has been a game changer for my family. Um, there's often an individual and family component, as you can see right below that with the acronyms. Family does come up a lot in the various names for in-home services. But part of the reason why it can be so powerful is that we know, particularly for children, nothing exists in a vacuum. I mean, you can say that for pretty much all humans, but when you are dependent on your parent or guardian, really, you're not kind of the only patient that needs attention in that sense. There are going to be things that your family will need to learn to be able to support you in your endeavors of staying safe and promoting your overall wellness and well-being. So it can be really helpful to have that therapist that works primarily with the child, but can also come in and be able to see some of the dynamics in real time and be able to kind of work with everyone to get to a place of improvement. As I said, there are a bunch of acronyms. These are just two, or I guess you could call it three, that come up most often, at least in my day to day. CCFT, CASTFIT. So with CCFT, that's usually 3 days a week. I kind of call that your like standard level of in-home services. Some folks on this call have heard me say that CastFit is like the Red Bull of in-home services. So you've got CCFT, and then you've got, if you want something a little bit stronger, you've got CastFit, which is usually 5 times per week. It's the most intensive. You're really trying to avoid having to step up to a more restrictive setting. And then below that, as I sometimes will call it, diet CCFT, for lack of a better word, that may be, instead of it being specifically therapy, it may be more on the case management level as well. And like I said, the goal is really, being able to do those in vivo real-time interventions and acknowledge the fact that the child is not just existing and behaving and, trying to get through on their own. It's really about the system and improving the system. So going a few steps up from there, so intensive outpatient. Some people will also lump this in with the next category, partial hospitalization. I kind of go back and forth. Sometimes it's helpful to lump them both together. For some families, for others, it's helpful to really focus on the differences between the two from a matter of logistics and being able to meet that patient and family where they are. And so usually, and again, it really varies based on the program. There are some programs that, the numbers that I've put here for duration and frequency may not apply at all, but often the ones that we're interfacing with and referring folks to from our setting, this is usually what I will tell folks to expect, give or take. So you're looking at maybe a 6 week overall duration, maybe longer. You're looking at a couple days a week. Often it'll be in the afternoons, a few hours a day. I said 3, but maybe 2, maybe a little bit more than that. Often the things that, you know, if I'm working with a patient where I might want to recommend partial hospitalization, but they're really worried about missing school, if an IOP is available, that can be a good way to get some of the same benefits of that, just a step down from inpatient level of care without them having to sacrifice school. And um, particularly if you've got a kid that is like, school avoidance is something that you're really worried about, this can be a good happy medium between the two to be able to not take them away from the environment that they are trying to avoid, because if you avoid it, it will be much harder to get back into it. But still be able to give them something intensive. There's more of an emphasis with IOPs on more group therapy. There is med management available. There are some programs where a psychiatrist or a psych NP is available kind of as needed. There's some that, they will be there and they will see each patient on on occasion, it really kind of depends on how the program is built. But the thing that is similar across most is that group therapy is a pretty huge component. Some IOPs will target specific patient populations or diagnoses. Some are a bit more general. There's always some that, if I have a patient coming in with a certain cluster of symptoms, it's gotten to the point where I will immediately think, this would be a good kid for this program, and hope for the best in terms of eligibility and logistics and all of the rest of the things working out in terms of that clinical recommendation. So in my mind, I think of the goal as you need more than just office visits, but you're trying to prevent having to go all the way to inpatient. And plus or minus, for some reason, partial hospitalization may not be available. Um, and so I put, looking at the kind of color gradient here, intensity, it's up there. I mean, intensive is in the name, of course. For restriction, I put this a little bit higher than your standard kind of outpatient just because it is more of a time requirement. So you may have to sacrifice a few evenings at home. You may have to sacrifice if you have something going on after school that happens to fall with that program. That's something that you would have to potentially, not engage in while you're doing this program, depending on just how the scheduling works out. So in a way, you could think of it as a bit more restrictive than some of the others. And then duration, not exactly in the middle, but not exactly at either end. And we've talked a little bit about PHP here. So I think of this one as mental health, but make it school. So, 5 days a week for Vanderbilt's program, it's Monday through Friday, 8 to 2, for a total of 15 days, so 3 weeks. There are some programs that go longer than 3 weeks. It really just depends on how that program's designed. Um, it tends to be a combination of group therapy, some family work, and medication management. Sometimes people will wonder about individual therapy. It can happen in that setting, and I've got some colleagues that do more PHP than I do, because I currently do none, but I've been in that setting before. I have some folks that could probably, give a little bit more insight into how much individual work happens in the midst of all of the other things, but I will say that is typically not the emphasis of PHP. It's really more about um, the other pieces of that puzzle. In a lot of ways, it's obviously less restrictive than inpatient because you can sleep in your own bed at the end of the day. You don't have to be on a locked unit. But in a lot of ways, because the inpatient setting is trying to meet so many people where they are in terms of, their previous mental health knowledge, previous treatment, the ability that they're like the level to which they're able to engage, whether because of their symptoms or just because of their general level of motivation. Inpatient groups and programming has to meet a lot of people where they are in a way that PHP doesn't. So I think of it as less restrictive than inpatient, but in many ways more intensive because you're able to be a bit more targeted and you really have kind of selected a population that is able to and motivated to engage. So I think of it, you can think of it as a step down from inpatient, or you can think of it as preventing a step up to inpatient. So we have folks that, may come into the emergency room for an assessment and they may get referred to PHP as an alternative to inpatient. We have folks that we will discharge from inpatient and walk them right downstairs to their first day of PHP. It really kind of just depends on the situation. I kind of put restriction in the middle. It's again like it's really because you are not able to go to school. You're not like there are a lot of things that you're really not able to do because of the way that that program is set up. And so in that way, you can think of the people and the settings that you would normally have access to, you may not have the same level of access to. So I think of it as more restrictive in that way. Um, duration a little bit shorter than IOP, and then intensity of not all the way towards the end, but pretty up there for the reasons I mentioned. And then we've got inpatient. This is pretty much where where my work lives. Um, I still give the spiel of the average length of stay is about a week, longer or shorter depending on individual needs. Really, the biggest things, our focus is safety and stabilization. And so, at least for us, I will get the question from families like, so does that mean that after 7 days, no matter what, I have to leave? And the answer is no. Really, our biggest thing is, if we get to day 6 or day 7 and we still have a lot of things that we need to do to be able to stabilize this acute crisis, that to me means a lot more than that number does. And for other folks, there are times where at the time of that crisis or that presentation, inpatient was the only option. But, within a day or two, the dust is settled. We've realized, okay, we do have access to another level of care, or we just needed a super quick medication change. We needed eyes on us for just a little bit longer and can transition out without having to stay that full time. And then if you've got folks that are very acutely ill and needing a lot of resources, a lot of med titration, a lot of monitoring. Sometimes that does end up extending their stay to multiple weeks, but that's usually not the intention when someone's first getting in the door. It is the most restrictive level of care that we have. Locked unit, there are certain things you can't bring on the unit, certain clothes you can't wear. We don't have we I had a kid recently ask me if he could get video games, and the answer was no. And it's not about whether they have wires or not. We just don't do video games on the unit. So there's a lot of things that you do not have access to, which for some people can come as a pretty jarring surprise. And so that's something that we try to prepare people for when we can, but sometimes there's only a certain level of preparation that you can give. The most important thing about that level of restriction, things like sharps and knives and, things that could potentially be hazardous are not available to those patients. And, they don't have ready access to their medications. And they're on some level, at the very least, monitored every 15 minutes, if not someone with eyes on them at all times or within arm's length for safety. You've got a pretty decent hodgepodge of different treatment approaches: medication management, group therapy, individual work, family work. You know, it's some folks will hesitate to call it family therapy formally because that kind of implies a longer kind of treatment relationship than you're really able to do in the acute setting. But again, since children are not existing in a vacuum, it's really important to, at the very, very least, kind of hit the high points of safety planning and in those recommendations to be able to get the child safely to the next level of care. As I mentioned before, we cannot do psychological testing on the inpatient unit. And one of the biggest reasons for that is, well, first, I'm not a psychologist, so I don't actually have the training to do that. But also, when you're seeing someone in crisis, that would not be the time where you would get the most accurate results of that testing. So the goal, as I think about it, some people will say safety and stabilization. I think of it as addressing the active right now risk or crisis. So if someone is at acute and imminent risk of harming themselves or harming somebody else, and there's not another level of care that's available that would be less restrictive, that's when we're sometimes thinking about inpatient. Most of the time thinking about inpatient. There are some times where we also are weighing, would it actually be beneficial to do an inpatient stay, or is there another way that we can approach harm reduction? So there is a bit of nuance there, but those are kind of the main, addressing the active right now risk or crisis. Um, and as I mentioned, inpatient, I kind of think of as the psychiatric equivalent of the ICU. you come in with an acute crisis, there's something that needs to be stabilized, and if it's not stabilized, it would be a significant risk to your health and well-being. So we need to do what we can in that short term to get us out of the crisis mode and then, step down to the appropriate next level of care. So I will often say that this is inpatient is where work is started, but not where work is finished. And then looking at residential. So we will sometimes get folks that think that our inpatient setting is actually a residential setting, which is always an interesting conversation to have after the fact. Residential is longer term, often on the order of months. Depending on the situation, it may even be longer than that if it's more of a custodial residential setting, if someone is in DCS custody or, there's a kind of complication in that regard. These programs will vary. So, the areas of focus and the ways that they approach it, the ways they approach school as well, that will kind of depend on the individual program. There are some that are more specific for OCD. There are some that are really more focused on kind of trauma-based treatments. There are some that, have kind of a focus on dual diagnosis. So we're looking at substance use treatment as well as how that plays into mental health, so in terms of mood, anxiety, etc. So it really just depends. And because the programming and what's available at those programs can vary, there's also variability in the restriction level. So there are a lot of programs that may have various levels. So when someone starts out, they're on the most restrictive level. They don't have as much access to things. They, maybe can't engage in some activities. But as they get through their treatment plan, and as they kind of improve, that can be stepped down, and maybe they can have a bit more access to other things as they kind of progress. And every program kind of does that differently too. The emphasis is often more on therapy than med management. You've got a more consistent kind of therapy team, but in terms of the med provider, often, whereas on the inpatient unit, you're seeing your med provider pretty much every single day while you're there. In residential, it may be more like once a week, or it may be a bit more intermittent, but you do have that consistent therapy team, and you do have those consistent folks that are there with you on the unit, working with you on the specific things that sometimes we're not able to accomplish as well on the inpatient unit. The goal is intensive treatment, but not acute, in a secure environment. So this is for somebody that maybe, we know that a specific therapy program or a specific approach would be really helpful, but because of the risk, they need to be in a secure setting to be able to successfully kind of get that treatment that they need. So for some folks, if they have an extensive history of trauma, often those trauma-based treatments can be destabilizing before they are stabilizing, for example. And so if it's someone that is at very high risk, you may think about a residential setting where they're set up to be able to manage if there is that destabilizing period. Whereas if they were outpatient, you may end up looking at an inpatient stay or interruptions in that treatment that would kind of delay getting to the progress that you're wanting. And I kind of think of this as, you've done your ICU and you need some more physical therapy, occupational therapy, but it's skilled enough that it wouldn't be something you can just do by yourself at home. So inpatient rehab, skilled nursing facility, that's kind of where I conceptualize it in my mind. So considerations. So a few things here, and this is not an exhaustive list by any means. Um, One of the biggest things is risk versus benefit. So just because you can hospitalize someone doesn't mean that it'll help, and does not mean that you should. One example, we may have patients that, you know, will unfortunately get to a point of using the inpatient psychiatric hospital as a tool for avoidance. It may be school, it may be a significant stressor that they are just not really able to tolerate in that moment. And, you know, they have kind of they've been able to establish a pattern of, inpatient means safety, inpatient means I don't have to deal with this right now. And that's not to say that, that in itself is trivial. It's not to say that, there aren't safety concerns there, but you kind of approach it differently. There are nuances, like I said. You may think more about, instead of, if we're communicating things that would normally kind of make us look towards an inpatient hospitalization, but we kind of have that chronic history of several hospitalizations, or there's some other pieces there. We may think about, let's kind of move the needle a bit. Maybe for this person, them expressing thoughts of harming themselves, maybe that's a bit more chronic, and it's more about, what is how much intent is behind it, how much intensity is behind it. And so, there does tend to be nuance there, and it's not always a slam dunk. They said they're not safe, so we're going inpatient. And there can also be risk in the inpatient setting as well. Thinking about location, so not all services are available in all areas. As much as I would love for there to be a PHP on every corner, that is not the world that we live in. So sometimes those levels of care just are not accessible. And by similar vein, logistics, transportation can be a huge barrier. That's one of the things that we hear for our folks that we would clinically recommend PHP or IOP for. If their guardian works, or they are relying on public transit for most of their getting from place to place. Sometimes those intensive outpatient programs are not necessarily an option. That can be unfortunate. Sometimes there are virtual options, but then you have to think about, if someone's in a really rural area that doesn't necessarily have the best internet access, for example, it seems like it would be more accessible, but there are always those nuances and layers. And then the eligibility. So depending on age, depending on diagnosis, depending on insurance, as much as I hate talking about insurance with folks, that can really affect what's available. And in the case of things like residential, there are some services that require you to have tried other levels of care before considering, and before insurance will cover. Um, and so again, non-exhaustive list of things that we consider, things that we kind of look into when we're thinking about what level of care that someone might need. But these are often kind of the stopgaps, that should be taken into consideration to be able to get someone successfully to the level of care that they need to continue to kind of move forward and live their lives, and you know do the things that they would want to do. And so that's kind of the overview for levels of care. So I will pause here for any questions, but there is some bonus content after this about the myths of mental health. If we end up kind of hearing a bunch of crickets for a few minutes, I will move on to that. But any questions from anybody?
And now it's time for uncomfortable silence. Now, if anyone has a question, please feel free to ask, or you can put it in the chat and I will ask it for you. But this is a great opportunity to pick Dr. Ingram's brain if you can, if you will.
I just have a question around, I know that you indicated that in the inpatient setting, they wouldn't do the complete battery of tests, but I mean, is it what's presenting in terms of how the path to some type of diagnosis or treatment plan? Is that kind of, I'm just one, because I can see where the testing, like you said, it's too much to do. And if the person's not stable, or really not able to communicate in a way that's going to be helpful results.
Yeah. And so there are many diagnoses that we encounter that can be more, that don't require formal testing to diagnose. And so, we'll look at the clinical presentation. We'll also kind of gather observations from family or folks that know the patient very well. Um, we also, I will always say, I've kind of literally said this to families before, I sometimes I wish I could just pop the hood and just look at your brain and just know what was going on. But unfortunately, that's kind of what makes behavioral health and mental health kind of very much the art part of medicine, right? And so often we're looking at kind of our, for lack of a better word, best guess based on the information that we have. And it may take multiple hospitalizations or it may take collaboration in multiple settings to really get the full picture.
I think that's what we try to remind our families because sometimes they feel that the person went to the hospital and they should have the diagnosis and be able to solve the problem, and they don't quite, understand the nuances of what that timing means and the limitations of it in some
Mhm.
ways. And so, thank you. I appreciate that.
Absolutely.
Thanks, Eileen. Do we have any other questions for Dr. Ingram?
I was just going to ask, and I noticed, but do sometimes people, it's indicated to have multiple levels of care. They might start out in one level of care and then transition to another. Is that pretty typical?
That is fairly typical. And depending on, there's some programs and some networks that really function in that way of, I think of Rogers Behavioral Health, for example. They have various, at least in Nashville, they have various kind of partial hospitalization programs. And often once that patient gets to a certain point, they will automatically kind of step down to their IOP. Or, it could be vice versa. You think that IOP is the thing that's going to be the most beneficial, but as the patient kind of continues to go through the program, you realize that they're needing more support, and so you might need to step them up. And we kind of have a comparable thing on, at Vanderbilt in terms of, we do have our adolescent partial hospital program, and sometimes that patient will get there, they've been assessed, we've thought that PHP is what was needed, and they get there and they're in crisis, and I'm getting a call from the good Dr. McCool, who I think is still on this call, saying, "Hey, I need to step up a patient. Do we have a bed upstairs?" So having that sense of things as a continuum and kind of that flexibility is a huge benefit for a lot of programs.
I have a question. And I've know, like working at VPH, like we run into this issue, but do you ever have a patient that you're assessing for admission and they require inpatient care, but due to the current milieu and the unit acuity, maybe it would maybe do more harm than good. So what would you do in that situation? Like looking at various levels of care or maybe referring to another hospital?
Yeah, that is, I'm pretty sure we may or may not have encountered that today. I don't know. But so that can be really challenging. And I think that, sometimes it's as simple as, a patient is coming in, but we're already treating, their sibling on the unit. Or it can be that there was a patient we've had before, but we have another patient who they actually know from outside, or they've had previous interactions with, and it wouldn't be beneficial to have them in the same milieu. Or it could be, we've had folks that may have a significant history of a particular trauma, and we have to be really sensitive around like can they have a roommate, or can they tolerate certain things that may be going on at the time? So sometimes in that case, it can be, maybe it's just not at this hospital. Sometimes it's, maybe just not at this time. There are times where I've reviewed an admission and said, we can't do it today, but if we are still running into issues, I can look at this again tomorrow and see if the situation has changed. But that is a really common thing that we end up running into.
Do we have any other questions for Dr. Ingram? I always take the lack of questions, meaning you were very thorough in your discussion tonight. Do you want
I
to go?
usually take it that people are asleep, so I like that reframe.
Do you want to go ahead and address the myths that you were our
Let's
material tonight?
let us do it. Okay. We will see if my controls are still working. All right. So like I said, I gave this talk in like 2022. I believe Catherine Shull, I'm just calling people out here, may recognize this from so I did used to do work with the Vanderbilt Center of Excellence, and they would have monthly lunch and learns, and this is what I decided to do mine on. So addressing common myths about psychiatry. So I didn't do the whole talk in full here. I just kind of pulled out some of the specific myths, but off we go. So this comes up a lot. Having severe mood swings means you're bipolar. Usually no. So in the original talk, I went through all of the diagnostic manual criteria. But here, really the important thing is that, as many of us on this call know and have to, provide education on often, you know, the term bipolar does mean something very specific and, in the clinical realm. It isn't just, my mood changes a lot. It isn't just one day I'm happy, the next day I'm angry. Really you're looking at, are we are we going through periods where we are not sleeping as well or not needing to sleep as much? Are we, you know, more impulsive? Are we talking faster? Are we thinking that we can open 20 businesses and still go to all of our classes? Are we feeling that we have special powers, or things that kind of set us apart from others that are, really actually putting us at risk? And so, there are so many ways that that can kind of manifest, but the colloquial kind of version of bipolar or manic depressive is pretty different than the kind of clinical version. And other notes, the term manic depressive, we still hear it at times. It's not formally used. I have seen folks say that they have rapid cycling bipolar and they mean minute to minute. That is not what it means. Pediatric bipolar disorder does exist, but is extremely controversial. There's a lot of overlap between bipolar and trauma and ADHD. There's so many things that can weave together that can look like bipolar disorder might be the best explanation, but that kind of goes, Eileen, back to the question that you asked of, you know, how do you know? Like, how good of a picture can you get? Sometimes we're just seeing that snapshot in time, and we may not get the full picture right away, and it's important to kind of have that in mind. Um, on that note, it can be extremely hard to get a good history of mania, so that's why we have to keep the differential diagnosis broad. But we often will see folks in, depressive episodes, and we think that it's not bipolar, it's unipolar depression. But because of the time course and the way that the diagnosis often works, for lack of a better term, you know, sometimes it's, that third or fourth hospitalization where we see the mania that just was not there previously. So making sure that family history is taken into consideration and really trying to dive deep, particularly if you're in the acute inpatient setting and it's a patient that you've seen pretty frequently. It's something that it's always something to kind of keep in the back pocket that maybe the diagnosis is not what it looks like on the surface. And then just included a list of other things to consider. Please, please, please do not diagnose kids with personality disorders. Please, please do not do it. Let them continue to develop and let us see how things manifest from there. And also keeping in mind that, you've got raging hormones, you've got a lot of transitions, you've got your brain is still growing and developing. So on some level, what looks like it may be pathology may actually be normal development, if you can call anything normal. What is normal anyway, right? Okay. Next myth, talking about suicide encourages suicide attempts. It depends. Do we mean media coverage of suicide, or do we mean screening for suicidal thoughts, behaviors, and risk factors? So I feel like 13 Reasons Why is a dated reference now. I don't know if it's still relevant or not, but what we noticed when this particular series came out, there was a shift in, reported suicide rates or, calls into crisis lines and things like that, when a lot of these, you know, when a lot of these episodes were coming out. I did not include the numbers from the previous talk, but there were specific numbers about, the trend of the statistics just based on when episodes or seasons of 13 Reasons Why was coming out. And not to demonize that particular show, there are others. There have been ways that people have not been the most sensitive about, kind of talking about these things, and it's ended up doing more harm than good. So, there are some folks that have put in, best practices on how to report on things like suicide in the media. Reporting on suicide.org, at least as of 3 years ago, was an active site, hopefully still is. And then, this is, a lot of times addressing that elephant in the room is the best. Like, you can't really deal with what you don't address, right? And so, normalize, sometimes talking about it can really allow some things to lose their power. And, particularly for kids and teens where, being a teenager can be pretty darn isolating. Sometimes knowing that no, your brain is not the only brain that has been here before, and there's a way that we can support you around this can be really powerful in itself. This is a fun one. Antidepressants increase risk of suicide. Not exactly. So the black box warning, the culprit of many tough conversations I've had with families when trying to think about medications. So a little bit of background. In 2003, that is when that is when there were first kind of publications around, the public health advisory around increased risk of suicidal ideation in children and adolescents with, antidepressants. The black box warning came out in 2005. The warning was expanded past just children and adolescents to include young adults up to age 24, I believe. But what was found is that there were changes in the prescribing practices, but then there were also changes in the suicide rates as well. So what was kind of recognized was that after the black box warning, folks started prescribing antidepressants less in this population, and we ended up in very unfortunate ways, learning that the benefits still outweighed the risk. All right. Psychiatric symptoms are all in the mind. Far from it. We know that physical diagnoses can present with psychiatric symptoms, and the opposite is also true. The example that I'll often give is, when you are like me and you are giving a talk, you will start to sweat, your heart will start to race, and that is called anxiety. It is psychiatric and physical at the same time, and very, very common, and may or may not be happening right now. Okay. Hallucinations equal schizophrenia. Not always, particularly not in our youngins. So I've had the pleasure of undiagnosing people with psychosis many a time, particularly in the youth. Often, it's about looking at other signs and symptoms before you think about it as psychosis. Think about, is the reality testing there? Is this more so imaginative play? Is this someone that has kind of a lot of medical things going on and maybe delirious? Is this trauma? And just knowing that there's so much that we don't know about the brain, and so there's so much that we don't know about how our brains process the world. And so for some people, those hallucinations may be something that's actually very comforting, something they know isn't real, but still something that, for whatever reason, their brain has portrayed as, someone they see and someone they can talk to. Stimulants make kids with ADHD more likely to abuse substances. Not true. So there was thought that the opposite was true for a while, but the the most kind of quoted studies and the most referenced studies show that it's really, they're neither protective or increasing the risk. But what we do know is that untreated ADHD or other psychiatric diagnoses can, at least anecdotally, lead to, increased rates of using substances. You're trying to self-medicate, you're trying to figure out what's wrong, and that ends up leading down, an unfortunate path. So if you're suspecting something like ADHD, you know that impulsivity can be part of the deal. Better to treat it than to leave it untreated because you're concerned about potential risk of substance use. And ADD is the same as ADHD, predominantly inattentive type. Attention deficit is definitely a misnomer. It's less that you can't pay attention and more that you struggle to pay attention in the proper context. So maybe your brain is trying to focus on everything at once. Maybe your brain is not really able to focus on anything at all. Maybe you're hyper focused on one thing when you're supposed to be doing your job. Like it's, really the deficit is less in can I pay attention versus not, and more, am I able to apply that attention or am I able to filter out the things that I don't need to be focusing on at that moment? And that's kind of where the deficit is. Bad grades aren't a requirement for an ADHD diagnosis. This comes up quite a bit. Kids with ADHD often can learn to compensate for, whatever, whatever struggles they may be having due to untreated ADHD. And so sometimes it's a kid that may study for twice as long to be able to get that same grade as someone else, or someone who seems really chill and able to pay attention and do the things on the outside, but on the inside, there is a high level of anxiety that is driving them to perform, even though it can be even more exhausting. So it can really, there's so much that we don't know about ADHD. It may or may not kind of be a area of interest for me as well. And ADHD isn't something that just goes away when you're an adult. hyperactivity is often less apparent as you get older, but that doesn't mean that ADHD completely goes away for everyone. This is a fun one for me. Psychiatry and psychology are the same. No, they are not. Um, I will not read this to you guys because I don't want to insult anybody's intelligence, but here is kind of just an outline of some of the differences and some of the similarities. Psychiatrists do go to medical school. They do have a medical degree. Psychologists get their PsyD or PhD or educational doctorate, and they do a lot more things that I don't think I would have had the patience to do, although medical school and residency were not the easiest things either. And then in terms of scope of practice, very much oversimplified. If you're looking for meds, ask a psychiatrist or a psych NP. If you're wanting to rule out medical causes of symptoms, ask a psychiatrist. Formal psychological testing, ask a psychologist, not in an acute setting. Diagnosis can be either, both can provide therapy as well. Genetic tests can show which psych meds will work and which to avoid. Not quite. So this usually comes up in reference to gene site testing. And, when you get something that has green, yellow, red, it makes it seem like, okay, green means go, we can use these meds. Red means no, we can't use these. But it's less about that and more about how the body might process these particular medications. Is it something that someone metabolizes more quickly, so they may need a higher dose because it leaves their system faster? Is it something that someone's body might be more sensitive to this particular medication? It takes them longer to process. So if you give them what might be a standard dose for one person, it may actually cause them side effects. So it's not saying that you can't use all of the medications in the red zone. It's more about how careful or how mindful do you need to be about how you're administering this medication. There are times where if somebody has tried a whole bunch of different medications and you keep hitting a wall, that may be a time to revisit, what are the things in the green or the yellow? Have we just been in the red? But it's not like a one-to-one, these meds bad, these meds good. And then honorable mentions for this particular talk. OCD is not another word for neat freak. Self-harm and threatening suicide are not just manipulative or attention-seeking behaviors. Like I've kind of tried to reclaim the term attention-seeking because it's like, okay, this means that there is attention that needs to be paid to like we are trying to communicate something that someone needs to pay attention to. So in a way, it is attention-seeking, but the connotation of the term attention-seeking is so negative. But that's just kind of something I keep in mind. It's like, okay, but we do need to pay attention. This doesn't mean that we don't pay attention. And then people with mental illnesses are not more likely to be violent. They are more likely to be, unfortunately, victims of violence. So, all important things to note. And we have some helpful resources, of which NAMI is included. And I believe that is the actual end.
All right. Well, thank you, Dr. Ingram. And thank you for bringing up that as someone who manages their OCD, I often have to explain to people that doesn't mean I'm neat. That means that I have anxiety around certain things like symmetry, etc. So I appreciate that. If you don't mind, Dr. Ingram, I'm going to give everybody one last chance. If you have any questions, this is the time to do it. And then I'm
Speak
going to
now or forever hold your peace.
yeah, exactly. And then I'm going to wrap up our program tonight. So, does anybody have any further questions? Yes,
Hey
Alan.
Don, I had a question for you specifically. Where would I be able to get the recording? Because all of this is useful information that even though I go over it with families and patients,
Mhm.
could be like a good reference of like
Well,
in your own time, please
I,
go watch this.
I can definitely answer that for you. One, the audio recording will be on our YouTube channel more than likely sometime mid-morning tomorrow. Anyone who
Okay.
registered, and I know that registered for tonight is on the newsletter. A link will be in the newsletter on Monday, but if you want to be proactive, probably tomorrow afternoon, you could go on our YouTube channel, which is NAMI D Info, and look up this exact presentation. Also, Dr. Ingram has been gracious enough to share this PowerPoint with all of our registrants. She'll be sending it to me, and I'll email it to everybody once I receive it. So you'll have the presentation and the audio version that you can refer people to.
Oh, perfect. Thank you so much.
You're welcome. Any other questions? All right. Well, before we close out our evening, I want to let everybody know that we do hold education sessions throughout the year. Our next one will more than likely be mid-October. We're going to have someone out from Park Center talking about SSI and SSDI uh, benefits and the process that goes along with that. Plus, in January, we will be having Dr. Joseph Pandit, a good friend of NAMI, who's been out to our classes and done virtual education sessions before on understanding psychiatric medications. And I'm always open to suggestions. As long as we can find a presenter, I'm more than glad to hold an education session. And one last thing, I want to do a real quick plug for our next upcoming event. Earlier we were talking about NAMI Walks, which is in May, but the first Saturday of October, as part of Mental Health Awareness Week, we will be having our fourth annual Glow Walk at Scarrett Bennett, their labyrinth. It's located downtown near Vanderbilt and Belmont. This will be our fourth year doing it. We'll have small world yoga, leading 20-minute yoga flows. Traveling light therapies will be offering Reiki education and 10-minute mini sessions. Healing Arts Project will be leading an interactive art table, and we'll also have a expressive writing area. Plus, again, it's a beautiful. Keep your fingers crossed for good weather, but it's always a beautiful night with the illumination and a time to reflect. We encourage people to enter the labyrinth with their problems and exit with hope. So we invite you all to do that. You can register through our website, namidavidson.org, or just reach out to me at outreach@namidavidson.org. So with that, I want to thank Dr. Ingram for taking her time tonight to present, and Tracy for coordinating our Vanderbilt Behavioral Health collaboration that we've been doing it for over a decade. Always good to have the best minds in Nashville come and talk to us. So with that, I want to thank Dr. Ingram and say good night to everyone. So good night.
Thank you.
Everybody, see some of y'all at work tomorrow.